Good morning, everyone. For today's CEU session, we'll be looking at the critical appraisal of a cohort session using a Casp checklist. So let's start off with a case scenario. We have a 45-year-old Mrs. L who consults you on OPD. So she's a diabetic and has been on metformin and dapagliflozin for the past 2 years. Her HbA1c is 8% and her BMI is 30. She has no other comorbidities. She is worried about her weight. You consider switching her from dapagliflozin to semaglutide, as semaglutide has been associated with weight loss. However, she is concerned as she has heard that it causes reflux. She asks you what are her chances of developing reflux. Hence, you do a literature review to confirm if GLP-1 agonists indeed have an increased risk of GERD as opposed to other oral antidiabetic agents. So the paper we'll be reviewing is published in the Annals of Internal Medicine. It's titled Glucagon-like peptide 1 receptor agonist and risk for gastroesophageal reflux disease in patients with type 2 diabetes. This is a population-based cohort study. So let's apply the Casp checklist. Are the results valid? What are the results? And will the results help locally? So the first question, did the study address a clearly focused issue? So let's look at the PICO statement. So the population they have studied were adults who are more than 18 years of age, who had a diagnosis of type 2 diabetes mellitus, who have received at least one anti-hyperglycemic drug between 1st Jan 2013 and 21st December 2021. The exposure they looked at was GLP-1 receptor agonists, and the comparator they looked at was SGLT2 inhibitors. The outcomes they studied was the diagnosis of GERD or the complications of GERD. The follow-up time in this cohort was 3 years. The study design was an active comparator new user cohort study, which was emulating a target trial. So what is this active comparator new user cohort study? So this is a type of cohort study which has two principles. It uses an active comparator and it also uses the principle of a new user. So this helps the cohort to resemble an RCT. It basically addresses methodological issues for which statistical adjustment alone cannot address in a cohort study. So if you look at an RCT, which is the gold standard, the participants are randomly allocated to the treatment group and the control group. So here what happens, all the baseline characteristics, that is confounding factors, will equally get distributed in the treatment group as well as the control group. But in a cohort study, what happens is, if you're following up a cohort, when the doctors give a treatment in one arm of the cohort study, they're actually carefully choosing. They look at the patient's baseline risk factors, their disease severity, and then they give a drug. For a mild illness, a doctor might not give a particular drug. So in a cohort study, what happens is the baseline characters will not be matched. So to address this, we have this the principle of active comparator. So in a cohort study, we end up having a bias called confounding by indication. So for example, in this picture, I've taken this from a rheumatology journal. So for patients with rheumatoid arthritis, if you want to give NSAIDs for pain relief, suppose the patient has a GI risk factor, as a physician, you'd probably choose a drug which has less GI bleed side effects. For example, COX-2 inhibitors. So patients with GI bleeding risk, the more likely that they would be getting a COX-2 inhibitor prescription. But what happens is because of the GI risk, the bleeding risk itself, what happens, these patients might have GI bleeding. And if you're doing a cohort study, you might wrongly associate COX-2 inhibitors that are associated with the GI bleed because of a spurious statistical association. So this is called confounding by indication. So to mitigate this, we use the active comparator principle. So drug A is compared with drug B instead of comparing drug A with no drug use. So patients in a cohort might not receive drugs either because they have very mild illness or they might be having so many comorbidities that you cannot give this particular drug to these patients. So in RCT, what happens is we normally exclude this group of patients. In this active comparator design, you might use, you'll actually compare the drug A and you look at the patients who have used another active drug for the treatment. So most likely these two patients will be having the same indications for using a second drug. So the advantage is it increases the overlap of measured baseline characteristics between the two groups, and it reduces potential for unmeasured confounding risk factors, and it overall improves the research question. So look at this picture. This is the cohort users of drug A. These are the cohort of patients who have used drug B, and this is a cohort of patients who have not used any of the drugs. So whatever you see above the surface is your measurable baseline characteristics. For example, age, gender, and disease severity. What you see below are things which are under the surface, which you cannot measure, like frailty, lifestyle. So the important thing to understand is when you actually do statistical adjustments, you're only adjusting for the measured baseline characteristics. You are not measuring for the unmeasured pre-treatment characteristics. So in this active comparative design, what happens is your baseline characteristics, that is your measured pre-treatment characteristics, also there's a more overlap as compared to drug A to non-users. And there's also reduced potential that your unmeasured confounding factors also will be more similar in users of drug A as well as users of drug B. And your third advantage is it improves the research question. So when you're actually looking at the side effect of a drug, for example, if you're applying in a clinical practice, you might want to start the patient on a second drug. So there is no point in having studies which actually compare the drug with the placebo where it's not indicated. It's rather useful for you if you have a study which compares two different drugs and see which is the lesser of the two in terms of less adverse effects. So that was the use of an active comparator. The main use is to reduce the confounding by indication. Now let's look at the second important principle, which is the new user design. So let's look at this particular picture, the panel A. Here, whatever is then the grade line is when the patient does not have a treatment. Whatever is colored is the period where the patient is receiving treatment. Whenever you start a drug, there's this initial high risk period where there's a high chance of adverse effects. Then there's the medium risk period where there's a less chance of adverse effects. Then there's the green area where once the patient tolerates the drug, they have a lower risk of adverse effects. So if you do a new user design, you're only recruiting patients who newly start the drug after you have started your study. So in this overall population, only patients number 2, patients number 3, and patients number 6 will be recruited in the study. And so new user design is when the cohort of patients who initiate a drug of interest begins follow-up after treatment initiation. This is similar to RCTs. So the start of your follow-up and the start of the treatment will align, and all events which occur after that are captured. But if you use a prevalent user design, you're basically recruiting all the patients who have either been on a drug and all the patients who will newly start the drug. So if I begin my follow-up here, for this first patient, I'd be starting the follow-up in the medium risk period. For patient number 4, I'm starting my follow-up in the medium risk period. For patient number 5, I'm starting my follow-up in the high risk period. But for patient number 2, 3, 6, I'm newly starting the follow-up at the time when they initiate the drug. So the follow-up starts at different time point in each individual during the treatment course. So because of that, we end up with an important bias called prevalent user bias. So here what happens is, suppose I start follow-up in this period. So for example, in this patient, patient number 1, when you start the study, the patient is actually untreated. For patient number 2, the patient is in the treated period. For patient number 3, he's an untreated patient who has subsequently, after the start of the study, has died. Patient number 4 has already been on the study drug and he has also subsequently died. Patient number 5 is untreated and he has not died at the end of your study. But what happens to this patient? These two patients have already started their study, have started the drug, and they have died early on in the treatment, in the high risk period of the drug use. But however, in your cohort, you will not capture this because the patients have already died before you started your cohort. So this is called depletion of susceptibles. That means if a patient already has a risk factor to develop an adverse event for that particular drug, that event will actually not be captured for these patients, and only patients who actually tolerate the drug well will be captured in the study. So this is called prevalent user bias, and one of the main side effects is depletion of susceptibles. The other problem with prevalent user bias is the baseline characteristics of patients who have already been on the drugs. It's more difficult for us to figure out. But all the new patients who newly start the study, like for example, this patient, we will have a accurate baseline characteristics for these patients. Then there is another kind of a bias, which is called an immortal time bias. So here what happens is, unlike a prevalent user bias where you sometimes start the follow-up after patient has started the treatment, in immortal time bias, we start the follow-up much before the patient actually starts the treatment. So for this, patient number 1 will be classified as treated. Patient number 2 is also classified as treated. Patient number 3 is an untreated patient who has died. Patient number 4 is also treated, and he also has an adverse effect, death. Patient number 5 is untreated. So here what happens in immortal time bias is, suppose you have a event in this untreated arm. So that will be taken as death in the untreated arm. Suppose you have a death in your treated arm here after you start your drug. This will also be taken into consideration as death in the treated arm. But what if you have a death here? So if you do have an immortal time bias, this will be attributed as if patient number 3. That means the drug has not been started, and it will be wrongly added as death in the untreated arm. So any event which actually occurs before your start of your treatment, in an this kind of a study design, what happens is the patient is actually in the treated arm is actually immune to any event which occurs in this period. This is called the immortal time. So when you use a new user design, it actually eliminates your prevalent user bias. It also eliminates your immortal time bias. Why? Because your time to follow up starts exactly when you start your treatment duration. So these are the advantages of using a new user design. Now coming back to a study, why did they use an SGLT2 inhibitor chosen as the comparator drug? So SGLT2 inhibitor is also similar to a GLP-1 receptor agonist in terms of it being recommended as a second or third line agent for type 2 diabetes, and it is widely used at a similar disease stage. SGLT2 inhibitor, unlike a GLP-1 receptor agonist, has no mechanism that is expected to delay the gastric emptying. But on the other hand, other medications like metformin delays your gastric emptying. Sulfonylureas and insulin also indirectly slow the gastric emptying due to hyperglycemia. The DPP4 inhibitor also stimulate GLP-1 activity, but their effect on gastric emptying is minimal. And other drugs are more, their use has decreased over the years. So the next question is, was the cohort recruited in an acceptable way? So they have actually looked at a database. They have looked at the UK Clinical Practice Research Data Link, the GOLD and the ORM database. So this is the acronym is CPRD. This is a large longitudinal database with records of more than 60 million patients from more than 2,000 primary care general practices. So CPR, basically the difference between the two databases is the software they use. CPRD Gold uses Vision EMR software, and CPRD Aurum uses MS software. Gold is more used in Wales, Scotland, as well as Northern Ireland, and Aurum is predominantly used in England. So the advantage of the CPRD is it has clinical data such as diagnosis, procedures. They're recorded using the read code or SNOMED CT classification. Any prescriptions which are written by the general practitioners are recorded using drug codes linked to the British National Formulary. And it also includes data on lab tests, lifestyle variables, and clinical measures. So the eligibility criteria in the study were adults who are more than 18 years of age who have already diagnosed with diabetes, and they have at least 1 year of medical history in a CPRD practice. And they should have also received at least one anti-hyperglycemic drug. So from this eligible population, any of the patients who were newly prescribed a GLP-1 receptor agonist or an SGLT2 inhibitor during the study period were entered into this cohort. So they conducted the study from 2013 till March 31st, 2022. So exclusion criteria was, suppose any of these patients had been prescribed the exposure or the comparator drug in the past 1 year, there is any diagnosis of a contraindication of a GLP-1 receptor agonist. For example, if the patient had a CKD stage 5 or the patient had a multiple endocrine neoplasia, because GLP-1 receptor agonists have one possible side effect is increased risk of medullary thyroid carcinoma. And they wanted to exclude any diagnosis of GERD or any GERD-like symptoms, other esophageal disorders, and any patient who has been treated with proton pump inhibitor or histamine 2 receptor antagonist in the past. Then prior diagnosis of GERD-related surgery also. They also wanted to exclude the diagnosis of medical conditions which can actually delay the gastric motility, so gastric emptying. So, for example, any esophageal dysmotility syndrome, scleroderma, SLE, Sjogren's, myositis, gastroparesis, gastric outlet obstruction, radiation therapy, peritoneal dialysis were all excluded. So the outcomes, the primary outcome they looked at was diagnosis of GERD in the diagnosis code, and the secondary outcome was any complications of GERD. So what were the complications they looked at were a composite of Barrett's esophagus, esophageal stricture, and erosion or ulceration of the esophagus. And a history of GERD should be precede or be present at the time of the diagnosis of a complication. So these are the codes which they had actually used to screen for the primary outcome. This is basically in the READ code, and this is the SNOMED code. And these are the codes which they used in their secondary outcome. So overall, I would say it was directed in an acceptable way. Some of the good things they have done is they have avoided immortal time and survivor bias by using the new user design. And baseline characters would be better adjusted because of an active comparator use. And because they have done a population database, the findings would mostly be generalizable. The things which I feel like they cannot get from this database would be over-the-counter antacids are not captured. So we do not know if the patient actually had any previous GERD. And we also don't know if the medication adherence is captured, and medication switching also might not be captured. So was the exposure accurately measured to minimize bias? I would say partially yes. So the exposure was based on a prescription, which I think in the CPRD dataset would mostly be reliable. And only new users of GLP-1 receptor agonists and SGLT2 inhibitors were included. The time to follow up was at the same time as initiation of the new drug. So because of that, many other biases, which I mentioned, confounding by indication, prevalent user bias, immortal time bias were eliminated. And they have used an intention to treat principle in the analysis. So the problem is drug compliance might could not be assessed here. So if suppose you had done the study as an RCT, we could have probably ensured drug compliance by checking drug levels or counting empty blister packets or using electronic pill counters. So was the outcome accurately measured to minimize bias? I would also say partially yes for this. So GERD and its complications were identified using diagnostic code. This might be prone to misclassification. But however, the authors they have used coding algorithms, and they perform sensitivity analysis requiring clinical evidence. For example, if the patient also received a PPI prescription or any endoscopy referral. But the problem with this is some patients, like using a database to assess your outcome, is some patients might not have reported any minor symptoms to the doctor, and some patients may not have consented for endoscopies. So complications with GERD, like whether the patient would have had Barrett's esophagus or strictures, might have been missed. And the other problem is some patients and doctors might already know that GLP-1 receptor agonist is associated with reflux, so maybe they might have over-reported their side effects also. So the next question is, have the authors identified all confounding factors? So I will show you in the next slide. They have measured a wide list of potential confounders prior to the cohort entry. Their risk factors are roughly in these six domains. One assessing the SES, the one assessing their anthropometric and behavioral risk factors. They've also looked at proxies for diabetes severity, because the more severe the diabetes, more chance of them having a diabetic gastropathy. And they've also looked at comorbidities which affect the gastric motility and medications which affect gastric motility. And they've also looked at the overall health-seeking behavior. These are the characteristics which they have presented before weighting, and after using a particular model of propensity score weighting, these are the right side half of the table shows those numbers. So the top part is basically all the socioeconomic status, like their age, their gender, and that. And next is the anthropometric and behavioral risk factors like their BMI, the smoking status, and use of alcohol. And they also have proxies for diabetes mellitus severity, like the HbA1c level, the diabetes duration, the types of OHA used, and whether the patient had any microvascular as well as macrovascular complications. They have also looked at comorbidities which might delay gastric emptying. Um, and these are the medications which might delay gastric emptying. And finally, they have looked at the overall health-seeking behavior, like use of whether the patient underwent colonoscopy, regular mammography, PSA testing, and their annual vaccinations. And this last part is basically the year of the cohort entry of the various patients. One thing to note is they have stopped recruiting in March 2022. So at least from 2019-2021, the follow-up might be less than 3 years for a good percentage of patients, around 30%. Some of the potential confounding factors which have not been measured, which might play a role, is one is the physical activity. Next is diet, especially whether they were taking spicy food or fatty food in the meal times, and whether the patients have used any over-the-counter use of any proton pump inhibitors or histamine receptor agonists, and the SES score was not captured. So next thing is, how are the confounding factors analyzed? They have used a model called propensity score fine stratification for adjustment. So basically, the first step they have done is they have calculated the propensity score, that is the probability of receiving a GLP-1 receptor agonist versus an SGLT2 inhibitor by using multivariable logistic regression models to based on all the above baseline covariates. The next thing they have done is in both the treatment and the comparator arm, the propensity scores which are not overlapping, they have trimmed. Then the next thing they have done is they have stratified the treatment group into 50 size strata, and they have adjusted for the numbers of the comparator in each of these strata by giving them weights. So this entire way of adjusting is called the propensity score fine stratification. What is this propensity score method? So basically, they are used in observational studies to compensate for the lack of random allocation by balancing measured baseline characteristics between the treated and the untreated patients. So there are various types, commonly which we know are the propensity score 1:1 matching. Then there is another method called inverse probability weighting, which is different from what they have used in a study, which is fine stratification. I just thought I'll briefly talk about the different propensity score methods because we have a few statisticians here. This is actually taken from a AHA journal. So if you look at this particular picture, you have the entire population. The patients in blue are the control arm and the patients with red are the treated group. So if you look at this total and the shapes, each of the shapes actually talk about a particular group of patients with similar characteristics. So in the control arm, there are 3 circles, and in the treated group, overall, there are 7 circles. 4 hexagons in the control group and 2 hexagons in the treatment group, and 3 squares in the control and just 1 square in the treated group. So if you do a random allocation, what happens is at the end in your study, all the patients in both arms will be similar. So you'll have 50% of patients of the circles in both groups. If you do the propensity score matching, these are all for cohort studies. If you do 1:1 matching, what happens is for every circle in your control group, I will choose a circle from the treatment group. So at the end of it, you have 3 circles in the control group and 3 circles in the treatment group. So this is all based on whichever group has a smaller number, it's limited by that. So if you look at the hexagons, there are only 2 hexagons in the treatment group as compared to 4 hexagons in the control group. So we would find a hexagon for each of the patients in the treatment group. And finally, there's only one square in the treatment group. So we choose one square from the control group. So finally, this is the final population that we study in if we do a 1:1 match. Here, the advantage is it looks exactly like an RCT. I mean, in the sense like your baseline characteristics have been equally divided. But the problem is you can see that the some sample sizes significantly come down. So the other method is using an inverse probability weighting. So basically, it's used to estimate treatment effect when the control and treatment arm resemble the average study population. So there are three types of inverse probability weighting. One is the effect in the overall population. So here, your treatment effect when the control and treatment group will resemble your overall study population. So here for the treatment group, we use 1 divided by propensity score for the weighting. For control group, we assign weights by using this formula 1 divided by 1 minus propensity score. So at the end of your weighting, you get a population which is exactly similar to your overall entire population. The same number of circles, the same number of hexagons, and the same number of squares. This next method is inverse probability weighting, that is effect in the treatment group. So here it estimates the treatment group when the control population is weighted to look like the treatment group. So the treatment group propensity score is just given 1, and the control group is weighted by using the formula 1 minus propensity score by propensity score. So if you look at it, the treatment group remains exactly the same, and the control group is changed to resemble to look exactly like the treatment group. So these are the various methods of propensity score. So this is used to adjust for selection bias or confounding, and gives higher weights to individuals who are less likely to be included in the study. So coming back to a study, the secondary analysis, they have basically looked at whether the different types of GLP-1 receptor agonists have a particular association with GERD. They've also looked at the effect modified by age, BMI category, smoking status, duration of diabetes, less than 10 and more than 10 years, and severity of diabetes, and the use of opioids. They have also stratified the analysis by the line of therapy, whether the GLP-1 receptor agonist was prescribed as a second or a third or a fourth line therapy. And sensitivity analysis they have done to look for the robustness of the study. Some of the factors they have used was time weighting, inverse probability of censoring weighting. They have also required that the outcome of GERD should be clinically supported by prescriptions or GEC referrals or diagnostic tests. And they have repeated the entire analysis using the 1:1 propensity score matching. And they've also repeated the entire primary analysis using DPP4 inhibitors as an alternate comparator instead of SGLT2 during the same study period. So the next question is, was the follow-up of subjects complete and long enough? So they have mentioned that they would stop following a patient if the outcome occurred, or the death from any cause, end of registration with a general practice, and up to 3 years of follow-up, or the end of the study period, which was 31st March 2022, whichever occurred first. So overall, the median follow-up was 3 years for GLP-1 receptor agonists and only 2.7 years for SGLT2 users. But it's known from previous studies that for patients who have had GERD symptoms for less than 1 year, they have a 3% prevalence of Barrett's esophagus. But the prevalence of Barrett's esophagus goes to more than 20% among patients who have GERD symptoms for more than 10 years. So maybe for primary outcome, this 3 years would probably be sufficient. But for secondary outcome, I don't think 3 years follow-up is sufficient. As I showed, and most of the patients have been recruited during 2020-21. So almost 20% of patients would have had less than 2-year follow-up. So this is the flow diagram. So these are the patients who have been prescribed more than one anti-hyperglycemic agent. And out of it, they have looked at by applying the inclusion and exclusion criteria, they have chosen this many number of patients to be the eligible population. And among them, 24,721 were given GLP-1 receptor agonist, and 89,424 had received an SGLT2 inhibitor. And after there were other patients, almost 3 lakh patients who were eligible, but they did not receive either two drugs. They were given other OHAs. And the final numbers after the propensity score trimming, we have GLP-1 receptor agonist 24,708, and in SGLT2 inhibitors, we have 89,096 patients. So let's go on to the part 2. What are the results of the study? So in 3 years, the GERD in the GLP-1 receptor agonist risk was 3.1, and in the SGLT2 inhibitor, the risk was 2.4. The overall risk difference was 0.7. So the risk of GERD was more in the GLP-1 receptor agonist arm, and the final risk ratio was 1.27. But it's interesting note that at 1 year it was 1.62, at 2 years it had become less, it was 1.32, and at the end of 3 years we have 1.27 as the final risk. Complications of GERD at 1 year, the risk in the GLP-1 receptor agonist was 1.28. 1.28. However, this is not significant as the confidence interval crossed 1. And at 2 years also it was not significant. But at the third year, we have a risk of 1.55 with a confidence interval of 1.12 to 2.29. So this is basically the weighted Kaplan-Meier curves, which shows that the risk in the GLP-1 receptor agonist was the cumulative incidence of GERD was more. And this is and the complications of GERD was also more. So I'm not put all the secondary outcomes, only important ones I have put. So it's interesting to note that actually liraglutide and dulaglutide had statistically significant risk ratios. Semaglutide risk ratio of developing a GERD was very minimal, 1.14, and the confidence interval was 0.81 to 1.49. But it's very important to notice that this Ozempic, that is semaglutide, was launched for type 2 diabetes in the UK only in 2019. And that means most of the patients in the overall cohort who have received semaglutide would have received only in after 2019 and 2020-21. So most of these patients, the follow-up would be definitely less than 2 years, 2 to 3 years. So maybe the time duration was not enough to capture more of the adverse effects. Because we have a similar study in an obesity trial where more than 50% of the patients actually complained of GERD symptoms. If you look at the other uh, secondary analysis, when they looked at it for smokers, they have found that it was actually on the patients who smoked, they had an increased risk of developing GERD. And on patients who had developed, who had comorbidities which decrease gastric motility, for example, Parkinson's disease, hypothyroidism, hiatal hernia, peptic ulcers, IBD, pancreatitis also, the comorbidity, the complication was more. They have done a sensitivity analysis, which I had mentioned before. So using the inverse probability of censoring weighting, this is actually to compensate. This is basically adjusting for all the patients who were censored from the study. They found similar risk ratios, and for patients who had when they had repeated the analysis, when they had confirmed the outcome of GERD to be clinically supported by prescription of proton pump inhibitors, they found a similar risk ratio. When they used a propensity 1:1 score matching also, they found the risk should be around 1.23, and but the complications was not significant. And when they used DPP4 also, it was not significant. This is just a forest plot which summarizes the results of the sensitivity analysis. So using the this is the primary outcome, the normal analysis, using the inverse probability of censoring weighting, alternate outcome definition, and propensity score matching, it was significant. Comparison to DPP4 inhibitors, it was not significant. For complications of GRD was significant only when using the inverse probability of censoring weighting. So now that we have looked at the results, let's go to part 3. Can the results be applied to the local population? Yes, because this was an overall, it was a population-based cohort done in a general practice clinic. And if you look at the baseline comorbidities also, most of them were young females who were obese, which is very similar to our OPD patients. So what are the implications of this study for practice? So let's look at the number needed to harm. The absolute risk increased by 0.7%. So the number needed to harm was 1 divided by 0.007, which is 143. So for 143 patients treated with GLP-1 receptor agonist instead of SGLT2 inhibitor, one patient will develop GERD in 3 years' time. So let's look at the Bradford Hill criteria to look at the association. So if you look at the strength, the risk ratio was 1.27 for GERD and 1.55 for GERD complications. This is a very modest magnitude. The temporality is strong because we have used a new user outcome, and the exposure preceded the outcome, and pre-existing GERD was excluded. So this is actually biologically plausible because GLP-1 receptor agonists delay gastric emptying. So it increases gastric distension. And it's coherent because the results are consistent with the pharmacodynamics of GLP-1 receptor agonists. Uh, so here the biological gradient is weak in the study because there is no data in the study regarding whether they have used low dose GLP-1 receptor agonist or high dose GLP-1 receptor agonist. And the duration of treatment, which is on the primary outcome, did not show any correlation with the duration of treatment also. So the biological gradient would be poor. So consistency is good because there's a similar result in a prior step 8 study. Experimental evidence also, it's a little bit poor because we don't have any direct RCTs which compare GERD as primary outcome. In step 8, they have actually compared SGLT2 versus a placebo, where GERD was only reported as an adverse event. Uh, it was not counted as a outcome in the study. Uh, the analogy is other drugs that delay gastric emptying, like opioids, anticholinergics, are also known to contribute to GERD. And then another closely similar drug, DPP-4 inhibitors, also I looked at the evidence to see if it caused GERD. But however, we know that DPP-4 inhibitors do not slow gastric emptying, and similarly in the network meta-analysis, they found no correlation between DPP-4 inhibitors and GERD. So coming to specificity, it's poor because GLP-1 receptor agonists can cause a host of other GI side effects apart from GERD. And there are many reasons for GERD to occur, like for example, obesity, etc. So specificity is poor. So overall, I would say that GLP-1 receptor agonist appears to have a mildly increased risk of GERD when compared to the SGLT2 inhibitor. However, it's a very modest risk ratio. So I would still advise my patient to have a trial with GLP-1 receptor agonist, that is semaglutide. Thank you.